Hi, everyone. My name is Rachel Werner. I am the Executive Director of the Leonard Davis Institute of Health Economics here at the University of Pennsylvania. I am delighted to welcome you all to Alumni Weekend and to our session today. Each year, LDI hosts a special event for Penn's Alumni Weekend. While I wish we were here together in person today, I'm so pleased to be joining you virtually. For those of you who don't know LDI well, LDI is Penn's hub for health system-related research, policy analysis, and education. For over 50 years, the Institute has been a leader in producing influential research, analyzing the medical, economic, and social issues that influence how healthcare is organized, financed, and delivered across the United States. This work is conducted by more than 300 Penn faculty from across 8 different schools here at Penn, who are LDI's senior fellows. Today's panel on the impact of the pandemic on healthcare delivery is a great representation of one of the important roles that LDI plays here on campus and nationally, which is in convening experts from across disciplines to address important and timely topics in healthcare. Today, with more than 1/3 of U.S. adults fully vaccinated against COVID-19, and yesterday's announcement from the CDC easing mask-wearing restrictions for those who are vaccinated, we are on a path that seems to be headed toward a more normal life once again, and there's growing optimism on many fronts. But the backdrop to that is more than 15 months of a pandemic which has wreaked havoc across individual lives and across the world. During that time, health and healthcare have been on center stage. COVID-19 has demonstrated that even a colossal industry like healthcare, change can come quickly when necessary. A year ago, patients understandably avoided hospitals and clinics because of the risk of viral exposure, leading to quick opportunities for innovation, and also leading to questions about the financial stability and the sustainability of the current healthcare system. Healthcare had to quickly pivot from providing in-person care to providing telehealth. Care that had been previously provided in hospitals and in nursing homes was moved home, with wearable technology and other digital solutions helping to enable these rapid shifts. And all the while, the pandemic was disrupting the healthcare supply chains, putting the finances of hospitals, doctors' offices, and other healthcare providers in peril, and calling into question whether the healthcare system that we've built and come to rely on is durable enough to withstand the kind of shock that the pandemic provided. Many clinicians and health policy experts are now thinking about what we learned from the pandemic and what the post-pandemic world might look like. We are lucky today to have some of the best thinkers on these issues with us. Our panel will address the rapid-fire innovations that we have experienced, as well as the critical gaps the pandemic has exposed in our healthcare delivery system. And they will provide their insights on what the more permanent effects of the pandemic will have on healthcare delivery access and equity moving forward. With that, I'd like to introduce our great panelists who are joining us today. First, we have Kathy Bowles, who is a professor of nursing and also directs the Center for Healthcare Policy and Research at the Visiting Nurse Service of New York. Throughout her career, she has focused on how to use information and telehealth technology to improve the healthcare of older adults. She's also a proud alum of Penn Nursing. Krista Giacchiotti is assistant professor of medicine in Penn's Perlman School of Medicine, a health services researcher, and a practicing general internist. He's also the medical director of Penn Medicine's on-demand virtual care telemedicine practice, which scaled up dramatically during the pandemic. Carla Denise Edwards has spent her career thinking about and planning for the future of healthcare. She's now Senior Vice President and Chief Strategy Officer for the Henry Ford Health System in Michigan, where she leads its strategic planning, business development, and partnership initiatives. And she's also a proud Penn alum and serves on the board of advisors for Penn Nursing. Christian Turwish is a professor at the Wharton School, where he chairs the Department of Operations, Information, and Decisions. He also co-directs Penn's Mack Institute for Innovation Management. Much of his current work relates to healthcare and how to optimize the complex operations of our healthcare system, including its capacity to respond to the demands of the pandemic. So thank you all for joining us today. Krista, I wanted to start with you. So as I said in your introduction, you led Penn Medicine's telemedicine practice, and you led the scaling up of that practice in the early stages of the pandemic. Can you just describe for us what that experience was like as you scaled up the use of telemedicine and the challenges and the successes that you faced during that time?
Thank you so much for this opportunity, and really excited to be here with these panelists here who I actually hope to learn a lot from also. I've actually reflected on this moment so much over the last couple of months as we hit the 1 year mark. And, I think maybe I can give a couple stats just to try to understand. And, I'm going to also say our experience is perhaps not unique, but I think we've also learned a lot of lessons. Telemedicine on Demand is an outward-facing product. Essentially, it's an urgent care service, 24/7, staffed fully by nurse practitioners. We've been around for about 5 years now, and so have predated the pandemic. And then functionally, when the pandemic hit, everything just kind of blew up, as one would say. And, I think we really, truly, for the first 6 months, just felt like we were in a lifeline kind of moment, just to try to provide people access, allow them to be able to access care when care seemed limited or they were too afraid to seek that care. And over the course of last year, we went from where we were averaging anywhere around 5,000 or so appointments per year up to 30,000 appointments in the entirety of last year. And so you can imagine here that not only demanded a huge amount of infrastructure, but it demanded a huge amount of collaboration and innovation to be able to manage those patients that were coming our way. And we certainly were just one aspect of the health system that was ready to take on that volume. And now you can really start to imagine here that the rest of the health system also had to be able to provide a lifeline for their patients. What was also really unique about our experience was that we took that Telemedicine on Demand chassis and then really built off of it. And so we had a number of unique programs that got spawned off of it. One we're really quite proud of, which is called COVID Watch. And this is a remote patient monitoring program where we text the patients twice a day, checking in on their symptoms in an automated way. And then if patients escalated or said they were starting to feel short of breath, we were able to reach out to them within about 15 or 20 minutes, 24/7 a day, just to check in on how they were doing, and then to triage or escalate them up to an emergency department or to be seen. In total, between On Demand, the COVID Watch program, a number of other programs that I'll probably touch on later on, we've had over 4 million patient touch points in the last year. And so you can imagine here, we've moved here from all fully in-person type appointments to really kind of saying, my gosh, we really should think about how we can connect with patients while they're at home needing their usual care or needing their care for COVID. So I will say, on a personal level, I'll just quite frankly say it's kind of exhausting, to be quite honest. And I think a lot of us are still trying to recover and trying to figure out a way to recover on a provider, administrative level, or operational level here as we're turning the corner.
Can you just comment briefly on what you learned over the course of doing this from the patient's perspective? Was this good for patient care? Did people enjoy it? How did patients view these changes?
Yeah, I think initially my perspective on it is it was really viewed as a necessity. We, as many recall now, the first 1 to 2 months, most in-person practices were shut down completely, really up to essential services. Perhaps oncology was open because particularly, people were having essential treatments that were needed. But telemedicine in that early beginning was one of the few ways that individuals could connect with their providers or to just reach out if they didn't have a provider on hand. I think we're also still seeing, and this kind of lingered on for the next couple of months, which is there are people who were concerned about going in person. And so, we always said this mantra operationally was, are they safe and do they feel safe? Really, when it came down to it. And so we had to really help facilitate that aspect of it. And I think we'll certainly get into this too, which is really thinking about, now not only do providers have a year's worth of experience with telemedicine, but patients have a year's worth of experience with telemedicine. And what are really the implications, the feelings about it, the beliefs about what conditions they should be seen for, when is it safe to be seen, how much does it cost? And I'm excited to kind of dig into these topics, particularly with the other panelists too.
Yeah, and I definitely want to get to those long-term questions. Before we do that, I want to turn to Kathy Bowles for the next question. In addition to the rapid scaling up of telehealth that Krista described, we also saw a rapid shift of care to in-home care that was often we think of as being provided traditionally in the hospital or in nursing homes. That care was suddenly being provided at home instead. Can you tell us what we learned about providing care at home during the pandemic?
Sure, we learned a lot about providing care at home. So home health care really stepped up to the plate. They became a partner, a safety valve for the healthcare system to keep patients safely in their homes where they wanted to be, prevent institutionalization, be a safety valve to get patients out of acute care as the beds were filling up and capacity limits were reached. Home health was able to take that. They demonstrated the value of home health care. So we did a study in New York City right at the peak of the pandemic with 1,409 COVID survivors who came out of acute care into home health care and demonstrated great improvement from admission to discharge in their function and in their symptoms and low readmission rates and low mortality rates. And so home health care was able to help these people safely recover in their homes. So definitely demonstrating the value. The clinicians in home health were as big a heroes as anywhere else in the healthcare system, taking the risks to go into patients' homes and keep a close watch on patients. Telehealth, similarly to what Krista just said, really increased use of telehealth in home health care. Some patients weren't comfortable having clinicians into their homes, and so they welcomed the chance to connect either telephonically or via video for check-ins. But in essence, home health care was not at all prepared for the pandemic, and they really learned a lot about that preparedness. And I think if anything like this ever happens again, we'll be much better positioned to respond. But the availability of personal protective equipment, most of it was going to acute care. And so when it came time to start transitioning patients into home health, they were really scrambling to try to get the equipment to keep their staff and their patients safe. And so there are a lot of lessons learned there with that.
You mentioned that home health wasn't prepared for the pandemic. And that part of the way it adapted was the use of telehealth to really expand the types of activities that could be provided at home. Could you describe a little bit more about some of the limitations of home health and prior to the pandemic and how that might have limited previously the types of care that could be delivered at home and how that's evolved during the pandemic?
Well, I think the pandemic really increased awareness about home health care. And I hope that awareness continues. And actually, nationwide, the last publication I saw from Medicare was that only 11% of COVID survivors were transitioned into home health care. So I don't think they were used at the capacity that they could have been used at. So they do suffer with staffing shortages. So, a shortage of nurses to provide the care. People are fearful of allowing people into their homes, and so both, and that's in general, there's a high rate of refusals of home health care, and I think it's a limitation is that people don't understand the service and the value of the service, and so we have a lot of work to do to educate the public about the value of skilled home health care. In furthering their recovery after hospitalization or helping them to manage a chronic illness. It's an intermittent service, but people don't understand that it is a skilled professional nurse providing the services, social workers and physical therapists. Many times they think it's a home health aide who will help to cook and clean and dress them, and they will say things like, my family members can take care of that, and refuse the services. And so it's really important that we now have, again, shown a light on home health care and its value in helping very sick patients recover and avoid hospitalization.
Okay, thank you. So, Christian, I want to turn to you next. One of the things that you've spent a lot of time studying is the healthcare supply chain and having demand meet supply. One of the things we learned during the pandemic was that the supply chain wasn't all that ready to flex when there was a huge surge in demand, partly related to just-in-time ordering, things like that. Could you tell us a little bit about how well you think the healthcare system was prepared to deal with the pandemic and why, from that perspective?
Well, happy to. So I think in operations management, we talk about matching supply with demand. That means having the supplies, that be it capacity for care, or be it PPE or medications available when you need them. Now, all of our healthcare systems have been, throughout the world, been under a lot of cost pressure. And what do organizations do when they face cost pressure? Well, they cut off the slack, right? They get rid of empty beds. They make sure that they don't have like 3 weeks of PPE sitting there, but maybe only 2 days. They reorder just in time. They run the occupancy as high as they can. And that's not necessarily a bad thing. We call this lean operations. It's kind of really getting rid of the waste. And what's not to be disliked about that? The problem with these lean systems is they really don't like change. They don't like variability. We've seen this in many industries. We see this in the auto industry, which has been a pioneer of lean for many years, that when the supplier goes on strike, when there's a shortage in electronics these days, as you see in the news right now, the moment some change happens, these systems kind of very quickly fall down and fail very badly. And I think that's in part what we have seen in the supply chain of PPE, where we are sourcing things from far away with very little buffers in between. And then we have a supply shock less coming in, and at the same point, a demand shock with more being needed. And we're just not prepared for handling that. I think similarly on the care capacity, if you think about provider capacity, beds, ICU beds, also we have put pressure, partly for good reasons, we've put pressure on the hospital systems and say, like, don't hold so much slack. And now we go back and say, like, well, wouldn't it be nice to hold some more slack? And so I think that's the paradox that we're facing here.
And so, what do you think this? What does this experience tell us about how we should be doing it going forward? I mean, you said it's a paradox that we're facing, but like if you were to think about the lessons that we've learned about the supply chain and about the lean operations in healthcare, what's the right balance here?
So when we teach operations management, we have a saying that is in healthcare particularly painful to tolerate, but let me say it nevertheless. We call it buffer or suffer. You either have to put some buffers in or you will suffer when things go wrong, right? And so the first question is we have to make a decision whether we want to pay our healthcare systems for holding buffers, right? And if you think about running the local fire department, it would even cross your mind that you would pay the fire department for every fire that they basically turn out. Right, you would say, like, the fire department is here, they hold the capacity of the 3 fire trucks, and if these 3 fire trucks stand in the driveway 90% of the day, that's a good thing. But if you have Charlotte Denise and her healthcare system basically say, like, we're going to run our trauma center or our ICUs at 30% capacity utilization, you couldn't imagine that. So I think that's the first kind of dilemma. We have to be willing as a society to pay for readiness. And the second thing is I do think we have to revisit some of the kind of on the supply side provider capacity. I think we have to imagine ways of finding new pockets of capacity. You have seen this in other industries. I don't want to make a pitch for the gig economy and Uberization, but I think there's some lessons to be learned in building flexible capacity as opposed to the more rigid, because expensive, the more rigid, fixed cost heavy capacity that we're seeing in healthcare systems.
Great. Well, you set up Carla Denise well. So Carla Denise, I will turn to you now. Christian has done a great job describing the lean operations of healthcare systems and why we've traditionally run healthcare systems in that way. The pandemic obviously had major financial implications for the way health systems operate, related to the plummeting admissions to hospitals, which reduced revenue, the shortages of supplies, which increased costs. Can you just tell us a little bit about the financial fallout from your perspective of the pandemic in hospitals and health systems?
I was actually taking notes as my colleague Christian was talking, because I like that buffer or suffer. And I've been thinking really deeply about this concept of how do we pay for healthcare? There are going to be many hospitals and some systems that don't survive this pandemic. The subsidies that they received from the federal government helped them get through so that we could provide the services that were needed to those who needed it the most in our rural communities, even in our urban communities, and even some of the suburban communities. But once those subsidies go away, it'll be really difficult, right, to recover. A lot of the health systems were doing exactly what Krista and Christian and Catherine described, which is just serving right up to the max. Right? Using everything you have because there's no place to store excess capacity and there's no way to fund it. Currently, we use that EBITDA or any profitability to cover the cost of those who are uninsured and underinsured. We don't use it to sit and wait. And so what Christian is saying is that we probably need to have an infrastructure that's on the ready. I love the example of the fire department. I absolutely love it, right? Because this is the virus of the century, but unlike the previous 2 centuries, right, where we had such a global infection, we're going to see these types of viruses enter our ecosystem much more frequently with a lot more virility. And so therefore we need to be prepared. So from an economic standpoint, there are going to be health systems and hospitals that will do okay, and they will survive this and thrive. But how will they thrive? Will they thrive because they actually double down on being lean? So therefore they're not expending money on excess capacity and sitting around and waiting? Are they going to thrive because they decide to find ways not to cover the uninsured and the underinsured, and they double down on commercial patients, right? Or are they going to survive because they change the business that they're in? Any one of those is a good solution for the health system or the hospital, but is it a good solution for the public, right? Is a good solution for the public. So I do think we need to think as a community, as a nation, what's in the best interest of the public so that we can be better prepared for the pandemic. The hospitals and health systems are willing to be a part of that solution. But again, somewhere, somehow it has to be funded and paid for. And as we think about healthcare reform being a way to reduce cost, all of the bells and whistles that Krista and Catherine talked about actually increase cost, right? So we have to find a healthy balance in doing that. I'm really excited to say that similar to Krista's experience and what he described with Penn, Henry Ford Health System also saw almost a 3 times or 3x in the use of digital encounters and technology. It went up, exponentially high because there was no choice, came back down, but we're still probably about a 2x of where we were prior to the pandemic. And that may be sustainable. And so what it means is we have to think differently about where care is provided, how care is provided, and then how do we use that technical infrastructure to do what Christian described, which is create the predictive analytics for the wait and the ready. I think we actually could probably do this if we really leverage and harness data, information, health science, technology, but it's also going to require a commitment of our nation to say that we want to pay to be ready. We want to have the infrastructure to be ready.
Yeah, that's a great point. And your comments also remind me that part of it, I think, what we saw during the pandemic, part of the deep cracks that the pandemic revealed about the health system was the disparities that we saw in care that was delivered. And certainly the financial fallout is not going to be felt equally between hospitals that serve a disproportionate number of uninsured or underserved patients compared to hospitals that don't. Can you comment at all on what we've learned about disparities during the pandemic and how we might address them?
Yes. Well, those of us who are at the tip of the spear and have been in the trenches are unfortunately astutely aware of these disparities in healthcare outcomes for communities of color, for the poor, for the aged. And so what COVID did was it brought it to the surface, right? It really highlighted the disparate outcomes for people who are poor. And not just people who are poor, but for communities of color, regardless of their economic means and status, right? And so the way in which people are treated and their access to care, as well as I think the weathering and residual impact of racism, causes disparate outcomes for many, many populations in our community. And COVID highlighted that. We are still seeing the residual impact of that as the waves go up and down. Right now, what we're seeing is that the people impacted are younger. They're not as sick, but the mortality rate is still disparate among those African Americans, Hispanics, and Asians. And so there's a lot of work for us to do, not only to address issues of access that may contribute to that, economics that may contribute to that, but the weathering impact of racism that undermines our ability to fight infection. That contributes to that. So health systems and hospitals, and are really all of us, I think in total, it's going to take a community or village for us to figure out how to tackle the health disparities and inequities that COVID brought to the surface.
Chris, I know that these issues that Carla Denise is describing is something that you think a lot about, particularly as it relates to telehealth and what the implications of telehealth might be for disparities. Do you want to comment on that?
Yeah, actually, I was taking notes also on what Carla Denise was saying. I think it's just really said it eloquently and well. I think let me maybe say one thing first. We've been digging into the data to try to really understand this, and at face value, what we want to know: are digital tools going to make the divide bigger, or can it actually close the divide? And what's been challenging thus far is sometimes we see a stat. So we might see a stat that says that Black patients or rural patients are using telemedicine less here relative to white patients or relative to rich patients. And it's such a complicated challenge to solve because there's so many layers to it. And if I just broke it simply, you can really think about like the moment you try to pick up your phone to try to have a telemedicine encounter. So do you have the technology? Do you own a device? Do you have enough broadband, the right connection? Do you know how to use the technology? And then we finally get into these challenges of like, do you want to use it? Does your provider offer it to you? And we haven't even gotten to the whole crux of like what we always debate in healthcare, which is like, is it the right thing to use? Is it cost effective? And so you can imagine now if you walk down this entire cascade, when you talk about like a 20% or a difference of something, it can be built along all those lines. Let me say what I fundamentally believe. One is the digital divide is totally real. Device access, broadband access, 150%. And then there's also this other complicated structure too, which is like how we're breaking down the equity. So we can certainly have a conversation about race. We can also have source around age. We can have a conversation around rural versus urban. And each of these kind of create different choice architectures about how to solve the solution and how to go about tackling it to narrow the disparities. And then the final bit is that it's incredibly complicated. So we've looked at our data here, and one of the things we did notice quite upfront was that Black patients in our West Philly neighborhood were using telemedicine at a lower rate than our white patients were throughout the entire health system. Interestingly enough, though, when we looked at the data of show rates, now historically, many may not know this, but low-income patients, particularly minoritized patients, actually have higher no-show rates than other populations. And part of this is actually one of the reasons I'm in the field of telemedicine, because I've actually always fundamentally believed that the way we structure in-person care actually is a structural barrier. And I want to go as far as it's perhaps some form of structural racism that we like almost limit them to these choice architectures, these choice sets. And what leads me to say this is that actually because we're actually seeing the highest show rates we've ever seen amongst our low-income and Black patients in our health system. And part of this, I think, is it's because it's, I think, a gaining an access gain here. And so I think we have an opportunity here to think really thoroughly, like, what is the ways in which we can design healthcare moving forward so that we actually can close that gap? And whose gap are we now not going to close through telemedicine? And what are the alternative ways we can actually provide care to give them access? And so I think we're at an interesting juncture on the road to really think about the future here of healthcare.
Thank you. That's great. So we're getting a lot of great questions from the audience, and I'm going to turn to some of those now. Kathy, a question came in specifically directed at you about home healthcare and payment. And so traditionally, home healthcare has been paid either by Medicare for skilled needs or in some states by Medicaid through home and community-based services. How do you think the pandemic might expand the way that we're paying for home health care? Do you think there are opportunities here, and what are they?
Mm-hmm. I'm not seeing anything right now that's telling us that the payment's going to change in home health care. They've just adjusted the payment of January of 2020, shortened the episode and tightened up the payment in terms of Medicare payment. There is expansion in managed care to home health care. Some of the value-based purchasing programs are coming into home health care, and so that can expand access and payment for services. And so that's one way, but I'm not seeing much from Medicare in the way of change. All of the talk we've been doing about telehealth, within home health care, it's a real barrier to do telehealth because there is no reimbursement for it at all. Home health care is paid by the episode based on patients' needs, and you visit a patient for a period of the episode, you get a lump sum of money to provide that care. If you want to do telehealth within that amount of payment you receive, you're free to do it, but it's not reimbursed by the visit or payment for the technology or anything like that at this point. And so although home health agencies want to use telehealth and do use it, there's not a real incentive financially or reimbursement for it. There are some reforms coming down the pike in terms of trying to shift patients from skilled nursing facility care into home health care. And so I think we'll start to see that occurring. And those, again, are part of the value-based purchasing, where they'll be working with partners, with acute care partners, to provide the lowest cost care and the highest value care to patients. And that may help to improve access and payment toward home health.
One of the questions that's coming up, Christian, I wanted to ask you about, so you've done a lot of work in addition to about supply chains related to digital health and connected health. Kathy mentioned that payment for those can be challenging, and there isn't a uniform coverage across insurers. Can you first tell us a little bit about the role of connected health, and then a little bit about the business case for it, and which might motivate payers to include it in their payment?
Yeah, so telehealth is one of these wonderful things where you ask three people for their definition and you get probably 4 answers for that. Mm-hmm. And so let's kind of basically go with the first kind of, when people say telehealth, most of us, I think, are referring to virtual or some form of electronic office visits in the way that Krista has described them. I had the privilege and has the privilege with Telemedicine and Krista doing a research study on the usage of telemedicine at Penn. And so one thing that is, from a payer perspective, a really interesting question is that when you make it easier for the patient to see the provider, are patients over-consuming? So I had, via Blue Jeans this morning, a telehealth appointment with folks at Penn Medicine. It was just like our call now, except we didn't have 241 people watching, but it was otherwise the same experience. And for me, it was super convenient because I was sitting here in my suburban home. I was just clicking in at 8:29. I was in and out with no time. It was perfect. So the risk, or if I were in an insurance company, the concern I would have is that people are starting to overconsume. And again, that's some of the research that Krista and I are doing together with LDI. And again, our doctoral student, Tan Lekvijit, was just graduating this morning. Beyond this, there is this idea that, well, rather than just automating what we have or virtualizing what we have, right? Instead of me coming to your office for 25 minutes, I'm seeing you via Blue Jeans for 25 minutes. I think the next level of telehealth is really the connected health that I think Catherine mentioned in the home health introduction that she gave. It's just increased connectivity where we're monitoring patients, where we are surveying patients, where we're nudging patients to do certain things, all the way towards automated executions, where we have, in forms of artificial pancreas or other forms of implantables, we take actions without even the patients knowing that we take action. So there's a whole continuum from just waiting for the patient to come to us, towards being more parental, to being more overseeing, being more concerned, and empowering the patient to do more, all the way to empowering technology to do things on the patient.
So what is the business case?
Well, the business case is tricky. As I mentioned, the concern is that we have overconsumption, right? And so the insurance companies go like, well, look, this telehealth is bad because we're making it miserable. So I don't see an easy business model other than that you go from a more traditional kind of a health equity perspective towards the outcome that I think nobody wants here on this call, is that the rich people have the privilege of basically buying by the minute, so to say, and everybody else is stuck with the unconnected healthcare. I think the business case is on the payer side a very tricky one. Unless you have some form of price discrimination, you will have this differential access. I don't think there's an easy solution for that. I think we all can agree that taking the waste out, the inefficiency out, nobody benefits if I discharge a patient and the patient bounces back 3-4 weeks later because they haven't taken their medications, we haven't done the wound care properly. I think with the connected technology, there are things that are obvious waste that we can overcome. But I think with this digital technology, the discussion that Carla Denise brought up about inequity and kind of race, poverty, I think that discussion will even get more profound and gets more central as we're going to move into a more digital healthcare world. I wish I had an easy business case for that, but sorry to let you down on that one.
Thank you for your answer. Carla Denise, I want to turn to you with a question about payment and payment models in general. And so, as we all know, the healthcare system has largely been built on a fee-for-service payment where you pay for what you use. You pay out based on the intensity of care, how much care you use, rather than things like efficiency that Christian is talking about. Can you tell us how the pandemic has changed your thinking about fee-for-service versus an alternative way of paying, which is value-based purchasing or alternative payment models, and whether or not alternative payment models might address some of what Christian is talking about in terms of a business case for things like telehealth, digital health that can increase efficiency in care?
Christian is absolutely right. We have a conundrum right now in a fee-for-service world to build the business case for things that are more efficient and may actually reduce utilization of key services that are high earners, right, for a hospital health system. And so unless we get to a place where we actually want to pay for value and pay for health, right, and pay for readiness, we're going to be stuck with paying for sickness, paying for illness, paying for acute episodes of care. And so it's interesting how we use alternative payment models when we talk about moving from fee-for-service to value. And I really wish we could get to the place where value was the game, right? We actually invest, and I don't think it's payment, I think it's investment. We invest in the health and the wellness of the people of the United States of America, as opposed to investing in fixing people after they're broken. But I mean, it's just a huge endeavor, and it requires a political will and a value system that we may or may not be able to proliferate, given the diversity of opinions in our country. I actually looked at this pandemic as a huge opportunity for us to at least maybe shift the direction that the Titanic is going in away from the iceberg so that we won't actually hit it head on. Because we do recognize now, more so than we did probably a year ago, that we need a strong public health infrastructure so we can be prepared. I think we also recognize that we need to have hospitals and health systems that can multitask, right? So they can treat the acutely ill and not stop treating people who have chronic comorbid conditions while doing prevention and delivering babies. Right? I think we recognize that there are disparities that are just unpalatable. And so for me, the pandemic created an opportunity for awareness beyond the people who've been at the tip of the spear, and a recognition that change is not only important, but I think change is absolutely inevitable. So the question we have to ask ourselves is, what is that change? To answer your question, Rachel, I think we need to move closer to value, to instilling ways in which our healthcare system and our providers are incented to provide health. If that's capitation, I don't know. But if you use that as an example, paying per member per month, so you can take an employer such as the ones that were on the LDI call last week and say, hey, I have all these employees. I loved that conference call last week, the LDI had. Racquetball factory, I think the guy was from. And I want my employees to be well. I don't want them to be sick, right? So I'm going to pay you, managed care company or health system, Henry Ford Health would be nice, to say, keep my people well. So I take that capitated payment and I use telehealth. I use technology. I use predictive analytics to make sure they get what they need, where they need it and want it, and when, right? To keep them from coming to the high cost hospital or health center, right? And then I send them to that designated place that has the highest quality and the lowest cost in the event they do get sick, right? And so now we're competing on quality and we're competing on cost, right? Because I'm actually getting a sustainable payment for wellness. So as you can see, I have an opinion and a preference, but it's not one that's widely accepted or adopted because it's not the business that we're currently in. And it's absolutely disruptive to think about doing it any other way than the way we've always done it.
I think that among some people who are have been thinking about value-based payment for a long time, there's a hope that the pandemic may provide some momentum or some reason to really move away from fee-for-service and get some real change to implement the kinds of systems that you're talking about. Are you optimistic about that?
Yeah, I am, but I don't actually think it's an either or. I think one of the challenges that we've had, Rachel, is extremism. It's either or. It's either socialized medicine on one extreme or the current state on the other extreme. You know, we live in a pretty diverse geopolitical environment, and we live in a capitalist society. And so somehow we have to find the bridge between our political environment, our economic environment, to a solution that is consistent with what we want our outcome to be. And our outcome for the nation is to actually be competitive economically, to be safe, and to actually be a protector and friend to others. And so I have some optimism because of COVID, but I also think there's a lot of education that needs to be done and further research to help folks understand we don't need to go to one extreme or the other. We actually need to create something that probably doesn't exist. I can't use Switzerland as an example of what we need to do in the United States. We are not a homogeneous society, and we're not small, right? So we got to find something that I don't actually think exists before. And it's going back to our foundations. Our geopolitical economic system didn't exist before the United States of America ended slavery. So we created something that didn't exist before, and I think we're going to have to do it again.
Okay, thank you.
I think Krista was trying to jump in.
Oh yeah, this is great. I mean, I actually will give a couple like on the ground things that are continuing to happen, and maybe if we'll keep talking the telemedicine route. Right now, we're in an incredible debate, how much to pay for telemedicine. Like, it's like incredibly intense. And it's not just happening at the policy level, it's happening at the organizational level, and it's happening at the practice level. And so right now, there's uncertainty, and there may be something in the next couple of weeks here to kind of talk about what the price is. So there's really two options in front of us. One is, do we pay the same amount for telemedicine as we would in person, or do we pay less? Nobody's actually arguing for more. That's for sure. Now, the challenge is we're arguing for the per unit cost. And when we're arguing about the per unit cost, it's becoming really challenging on the ground to operationalize this, because I have to think about how do I structure my practice so that I actually do in-person appointments and then actually churn through the right number of telemedicine appointments to make this happen. But there's like little nuances. So, when you get seen in person, I can actually get an additional facility fee. You've used my building. And so now it's like, well, the incentive is actually quite clear in our capitalist economy. It was actually, I want to bring you in because actually I make more per hour per unit there. Interestingly, too, I want to maybe highlight this nuance for those who are patients, which is all of us, which is now you're going to actually see potentially some costs shifted over to you. And I'll give a key example. Recently on social media, it's been more and more examples of it that's been coming up. People have been getting surprise bills for actually patient portal communication. So people are getting a bill like of $25, $50, and they're like, I just emailed my provider, and my provider sent me a bill. I don't understand. But it's the same. It's kind of the same kind of conceptual thing that's going on, right? With telemedicine's argument the whole time from a provider standpoint was like, I was doing all this additional after-hours care. I was hopping on the phone. I was triaging things. I was spending 30 minutes on top of our like 15, 20-minute appointment to try to help coordinate your care, but I was never getting reimbursed for those things. But I was working until 7 p.m. or 8 p.m. And so, now we're kind of having this like really complex argument of like, here, and I'm also on the camp of like, well, if you make it a value-based system, it starts to free you up a little bit to say, like, I'm just going to do the right thing for the patient. And the patient's not going to get a surprise bill. You're like, we're just trying to get you better.
That's one vote for capitation, I would say. Kathy, a question for you. So some of the questions we've received have been about workforce issues. And you actually mentioned early on that there's a shortage of workers in home health, also in nursing homes, and it's a workforce that we have undervalued for decades. What do you think? The question actually is related to with the emergence of telehealth, supplementing the traditional types of in-home care that have been going on for a long time. I guess I have two questions. One is that a way to address the workforce shortage? And the second question is whether or not there's additional training that we need to consider for people working in home health to learn to use these new technologies and to really integrate them into the care that's being delivered.
Yes. I definitely think that telehealth could help inefficiencies in home health. The time it takes to drive to a person's home, person to person, and do those in-person visits could be really, gain a lot of efficiencies with telehealth. The problem goes back to the payment model again. The same restrictions is that the numbers of visits you must conduct a minimum number of visits in person. So right now that's 4 or 5 in-person visits during an episode. So they have to carefully titrate the amount of telehealth that they use. They're not reimbursed for it. And so it's not really an efficient use of their workforce at the moment. And then in terms of training, there's also buy-in from the nurses to use this technology. Some of them don't like it. It requires a lot more work on their part of installing the equipment, teaching patients how to use it, and then having to have a bank of people monitoring it and responding to the alerts and the data coming back from the devices that are in the homes. So it works in some instances and not in others. And I think we've got, as Krista's been saying, a lot of work to do to figure out how to most efficiently and effectively do this and for which patients it's most effective for. And in home health, another shortage area is in home health aides. So in providing more of the long-term care services and help with activities of daily living and trying to keep people aging in place. There's a massive shortage of them, and they're often are minority workers, low-paid workers, undervalued workers that we really need to do a lot of work on to improve their conditions, improve their education and training to be able to provide those much needed services.
Great. I guess maybe Christian, I'll turn to you, and I guess Kathy's comments remind me of when electronic health records were first being rolled out in hospitals. There was a study that was actually led here out of Penn showing that during those first weeks when physicians had to try and integrate that new technology into their workflow, it actually resulted in an increase in errors, an increase in workload, a lot of dissatisfaction. I wonder if you could comment at all about how to most successfully integrate digital technologies into workflow, and can that make us more efficient even in the short term?
Yeah, let me speak a little bit about a study that I did at Penn Medicine with my former doctoral student, Hassan Mabafa, Rachel, who you helped supervise and just got tenure at the University of Wisconsin at Medicine. So what we looked at when Penn Medicine rolled out the patient portal, you had basically a lot of kind of messages from patients coming to providers at all times of the day. We looked at the physician's work schedules before and after, right? Beforehand, you could see the work schedule was somewhat contained to the kind of the practice hours that you would see patients in from 8 to 5. But with these kind of the patient portal rolled out, you would see these physician workout hours really become crazy, and people are spreading really also the 7 days a week, 24 hours a day. You see like little points on their schedule where they were working. And I think that is a scary thought in many ways. I mean, I think all of us knowledge workers see this. I see this with students emailing me that increasingly the expectation is like, why don't you get me an email back on Sunday night? And I think if we have these, I wrote down Chris's data point of the 4 million touch points that he had over this pandemic. If we have 4 million touch points, somebody better thinks about how to organize workflows that are not just responsive and high value to the patients, but that are also sustainable for the providers. Because, I mean, especially given the labor shortages Catherine was just talking about, both on the aid side, but all the way up to the physician side, those workflows cannot just happen. I mean, somebody has to design them more.
So how do we do that?
Well, I mean, I think it starts like any kind of process exercise. It starts out mapping the process, collecting the data. I think more often than not, you will have to let go of the continuity of care and having always the same provider contact you, but you will have to be comfortable with having some other provider basically be on the old overnight call. You need prioritization that some messages, the system basically figures out that they don't have to be answered immediately, but they can wait until tomorrow or the day after. There are solutions to that I think we've seen in enough other industries, but I think in healthcare, for good reasons, we have focused first and foremost on the job of getting it right and making the medical quality there. But I think now we have to factor in the economic efficiency as well as the kind of the health and well-being of the resources, the providers that are delivering this care. So I think other industries have done a more conscious job of analyzing and improving their processes. I think in healthcare we see more and more of that happening, but I think we're there really only at the beginning.
Yeah. Okay. So we have about 5 minutes left, and I thought I would like to end with a question to all of you about if you could get the ear of the Biden administration or of somebody in Health and Human Services to give some advice about, based on what you've learned on the pandemic, the one change you'd really like to see moving forward to make our healthcare system more resilient, to really improve the way that we deliver care in this country, what that would be. We've got about 5 minutes left, so you can feel free to take about a minute to answer the question. Carla, Denise, I might start with you.
Me first? Okay. I'm torn between addressing issues of health equity and disparities and paying and reimbursing for the public health infrastructure and primary care. I think maybe if we could pay for and create the infrastructure for ensuring we're prepared and we do testing, vaccinations, and education consistently, and that we build infrastructure for people to have a primary care home, we may be able to address some of the health disparities. So if President Biden or Secretary Becerra are listening, I think we need to really double down on public health and primary care investments that are scalable and sustainable for every single community, regardless of economics.
You know, it's interesting. We haven't actually talked much about primary care during the past hour, so I'm glad that you brought that up and highlighted the importance of that as a general internist myself. Thank you, Carla, Denise. Krista, you're also a general internist. What do you vote for?
I don't know if this is like happening. I'm actually a primary care doctor. I actually see people in person after all this conversation. I would second that. I think mine would be twofold. One is primary care capitation, because I think it's really telemedicine just becomes a part of the toolbox. It doesn't become the thing. It just becomes a way to achieve a thing, really when it comes down to it. And then I think there are some regulations that have happened, and we didn't touch on this, but which is like interstate licensing regulations that have been really kind of have allowed care to kind of happen across borders in a way, particularly like in Philadelphia, where we can now care for people in New Jersey a lot easier and really think about those.
Okay. Thank you, Krista. Kathy?
Well, I have a totally different topic. It was touched on a little bit, but I'm going to elaborate on it a bit. And I think I would love to ask for my wish list about the electronic health record. So I would love to see it become more interoperable between settings. When we transition patients from acute care to home health care, we send either volumes of information or nothing. Or we're sending paper, and this is the 21st century. So the interoperability of our records, the usability of our records, that our clinicians are not overwhelmed with collecting information that no one ever uses, that it could be used in multiple places for multiple purposes, including for research, and that it could be more structured and standardized across settings so that we can, again, have ability to share it and compare our data across health systems. And I think that's the way we achieve a learning health system that we can then improve care based on our historical data of what we have been doing, what works and what doesn't work.
Yeah, I think that's a really great point. The degree to which care is siloed and fragmented because the different healthcare providers don't talk to each other is remarkable. I have spent a couple decades seeing patients at the VA where that doesn't happen because there's a universal record that you can see what happens to your patients no matter where they are, and it's a powerful tool.
Yeah.
Christian, you get the last word.
That this would be poor advice for the Biden administration because it might be political suicide. But I think we need more centralization in healthcare. We cannot have the fragmentation across providers, payers, states, communities. We need, for the power of technology, data analytics to play out, for the learning health system that Kathy mentioned, we need some central databases. And I think we have to work on the appropriate forms of de-identification to absolutely ensure patient privacy, but we cannot have happen what happened during the pandemic, where everybody was building their own apps and their own vaccination schedules. We need centralization, and that sometimes is a good thing for society.
Well, thank you. That's a good note to end on. I think that I appreciate all of you joining me today for this discussion. It was a really great discussion. I think that I learned a lot from listening to all of you. There have been many challenges in healthcare delivery during the pandemic, but you've all highlighted some of the, I think, things that we've learned, really important lessons that we've learned that we can act on and make the healthcare system more resilient, more equitable, and sustainable over the long run. So I hope that people were listening. Thank you, everyone in the audience who joined in today. And thanks again to our panelists. I hope you all enjoy your alumni weekend, and I hope that the weather stays as beautiful. Well, here in Philadelphia, I guess it's virtual. Here in Philadelphia, it's a beautiful day, so I hope you enjoy the rest of your weekend. Have a good afternoon, everyone.